ICSI or not, when you're planning to do IVF or in vitro fertilization, there's two different ways to fertilize the eggs and sperm in a lab, and you should have a discussion with your doctor about which one is right for you. So if you're planning to do IVF, stick around because today you're going to learn all about ICSI and whether it is right for you. I'm Dr. Lora Shahine. I'm a double board certified OBGYN and reproductive endocrinologist helping people do IVF and decide on ICSI or not for almost 20 years. I am so glad that you found this video. And if you are not subscribed yet, subscribe to this channel so you get my weekly videos all about reproductive health. There are two other ways to stay in touch and learn. Number one is my newsletter. Sign up in the link below to get my weekly newsletter all about fertility in the news, content that I've created that week, and products and books that I recommend for more learning. The second way is my fertility podcast, the Baby or Bust Fertility Podcast, with an episode each week. Anywhere you listen to podcasts, I'm doing interviews with experts in the field and fertility warriors, incredible discussions, and lots of learning. Now, today we're going to talk about a very important decision if you're planning to do IVF. To ICSI or not to ICSI? That is the question. I know fertility is full of acronyms, so let me explain. IVF is in vitro fertilization. It's a type of assisted reproduction in which the ovaries are stimulated to recruit and mature multiple eggs. Those eggs are retrieved out of the body, and in the lab, eggs and sperm are fertilized. In vitro fertilization, in the lab fertilization. At its core, that's what IVF is. Now, when the eggs and sperm are in the lab, there's two different ways that you can fertilize them. One is passive, where you just put the eggs and sperm in a dish. It's called conventional insemination. That was around since the beginning of IVF, first baby born 1978. The other option is an active form of fertilization called ICSI, intracytoplasmic sperm injection, ICSI. So it's much faster to say ICSI than intracytoplasmic sperm injection every single time. So that's why we say ICSI. Today, we are talking about that decision. How do you decide how the eggs and sperm should be fertilized? Because there's pros and cons to each. Today, we're going to go over four main topics. Topic number one, we're going to go over the difference between conventional insemination and ICSI and cover a little bit of the history of the ICSI procedure. Topic number two, we're going to go over the controversy around ICSI. If you have access to a procedure, why not do it all the time? And there's pros and cons. Topic number three, who should do ICSI? What are the indications and what does the evidence show? And topic number four, what are the risks of ICSI? Now stick around to the end of the video where I go over conversations I've had with my own patients trying to make this decision, and I'll leave you with some questions to ask your own doctor. Topic number one, what is ICSI and how is it different from conventional insemination? Talked about this a little bit in the beginning of the video, but let me be clear. So the first baby was born 1978. And ICSI was not available for treatment until the early 1990s. So before the early 1990s, anybody that was doing IVF used conventional insemination. It's a passive form of fertilization. Just put them together and check on them later. Now, this is not ideal for people with significant male factor. And there are times where people just put eggs and sperm in a dish, they look the next day, and none of the eggs and sperm fertilize. That's a horrible phone call to have to make to a patient. You went through all the shots. You went through the procedure to get the eggs. You are all excited about the next steps in trying to get pregnant. But after the day after the egg retrieval, the doctor has to call and say, I'm so sorry, there's no fertilization. None of the eggs and sperm fertilized. There are no embryos. We have to start all over again. So ICSI is an active form of fertilization in which one sperm is injected into one mature egg. So the eggs have a hard shell around them. They're called a zona pellucida. The sperm is selected very carefully and placed into a little pipette, and it's placed in through the zona into the egg, and the needle is extracted. So it's an active form of fertilization. It's not just putting eggs and sperm together and hoping that they like each other. You're actually helping with that process. ICSI was introduced as a treatment for significant male factor infertility in 1992. And it is an incredible way for some men to have genetic children that would not be able to, either with trying naturally or with low-tech treatment like intrauterine insemination, or even IVF, but with the conventional insemination, they just did not have enough sperm. There was a defect with the sperm. It's not able to fertilize the eggs. And there could be some fertilization issues, of course, with eggs. There's an amazing interaction between the egg and the sperm that allows for fertilization. So we think about ICSI as a male factor fertility treatment, but this failed fertilization, it could sometimes be due to the egg as well. But it's an incredible, amazing advancement in the field of assisted reproduction. And since the 1990s, we've had something to offer men, especially with significant male factor fertility. And it has become more and more popular over time. Topic number 2, what's the controversy around ICSI? Well, the use of ICSI has gone up astronomically. You can look at this in multiple different ways, but the use of ICSI has gone up significantly more than the diagnosis of male factor fertility. So there are people who are using this procedure that was really designed to treat significant male factor fertility. They're using it for other reasons. And the controversy is, maybe we don't have to do this intervention. Maybe not all couples need an active form of fertilization or ICSI to help with fertilization. Could we possibly be using it too much? Most of the stats or information or studies that I mentioned are going to come from one excellent practice guideline from the American Society of Reproductive Medicine, all about ICSI. In that document, which is available, and I'll make sure that there's a link to it in the description, in the video, it gives a history, it talks about indications, it lists tons and tons of research studies involving ICSI versus conventional insemination. So if I'm mentioning a study, if I'm mentioning a statistic, it is most likely coming from that particular document. For example, in 1996, only about 34% of all IVF cycles used ICSI as a way to fertilize the eggs and sperm. But recent years and recent studies have shown we're using it up to 60% of the time, and sometimes even more. So the controversy is, are we using it too much? Because there are actually studies that show that using ICSI without a strong indication does not improve success rates of the overall IVF cycle. And we'll go over that in just a minute. Topic number 3, indications and use of ICSI. So as mentioned, a lot of this information is coming from that ASRM guideline, and any references, anything you want to look at, you're going to find it in that incredible guideline. And one of the things that they do is they go through indications that people have decided to use ICSI and what the evidence shows. Like, is it useful? Does it help increase success rates or live birth rates if you're using it for different reasons? And they break it down into 7 indications, and we're going to go through each one. Indication number 1, male factor fertility. Now, evidence does support, if you've got male factor fertility, doing ICSI as a way to fertilize when you're doing assisted reproduction can help, and it is indicated. So poor sperm parameters, ICSI can be very helpful. Another thing is aspirated sperm. So some people have vasectomy, some people are missing the vas deferens. It's that tube that connects the testicle, which stores the sperm to get it out of the body and into the ejaculate. If there's a blockage or you're unable to get sperm out into the ejaculate to use, you need to aspirate the sperm. There's not a lot of sperm that comes out. You need lots and lots of sperm to even have fertilization with conventional insemination. And so if you're using aspirated sperm from a procedure to collect the sperm directly from the testicle or directly from the epididymis, then you need to do ICSI if you're doing assisted reproduction. Indication number 2, failed fertilization without ICSI in the past. So somebody's already been through an IVF cycle, they did conventional insemination, and they had failed FERT. None of the eggs and sperm fertilized. You should discuss all the options with your doctor, but I've absolutely recommended ICSI in a subsequent cycle and seen success, and the evidence supports this. Indication number 3, ICSI is often used and recommended if eggs have been frozen. So people freeze their eggs, the eggs have been cryopreserved. The shell around the egg is just a little bit more difficult to penetrate with conventional insemination. And most labs, including my lab at Pacific Northwest Fertility, recommends doing ICSI to help with fertilization if eggs have been frozen. So those first three indications are pretty strong: male factor fertility, failed fertilization in the past with conventional insemination, and cryopreserved or frozen eggs. Now we're going to get into some of the controversy. Indication number 4 is unexplained infertility. So people will often recommend ICSI if you don't know why somebody's not getting pregnant. So somebody can be ovulating, have totally normal female anatomy, totally normal sperm parameters, and they are just not getting pregnant, and maybe even have tried low-tech treatment like intrauterine inseminations, and they're still not pregnant, and we just don't know why. And the worry is that if it's a fertilization issue, like if that's why that couple is not getting pregnant, a really horrible way to figure that out is to go through IVF, egg retrieval, and do conventional insemination, then have to call the patient the next day and say, "I'm so sorry, we figured out why you aren't getting pregnant. It's a fertilization issue, but we don't have any embryos, and now we have to start all over again." So it's a pretty common thing to talk to patients about if there's unexplained infertility, but what does the evidence show? There's multiple studies trying to answer this question, and basically they show in different ways, and some studies have more power, meaning that they're studying more patients than other studies. But basically, if someone is doing ICSI for unexplained infertility and they're comparing groups, there is a higher rate of fertilization in the couples if they do ICSI compared to conventional insemination, and there is a lower failed fertilization rate in the couples that do ICSI compared to those that do conventional insemination. Now, interestingly, they don't always show a higher pregnancy rate or live birth rate in these groups when they're comparing them. But if you're the couple that has unexplained infertility and you're thinking about all the options, I think it's pretty strong to feel like I want to have more embryos available, and I don't want to have that 16% risk of failed fertilization if we do conventional insemination. One study in particular was a randomized controlled trial of 60 patients that were going through IVF with unexplained infertility, and they definitely showed higher fertilization rate, lower incidence of no fertilization. But when they did look at pregnancy outcomes, it wasn't different. So interesting study, only 60 patients. But in general, most of the studies support at least offering ICSI to patients with unexplained infertility that are doing IVF, but make a discussion, because not everybody who has unexplained infertility and goes through assisted reproduction will have failed fertilization or a lack of success. And it's just really important to talk about all your options with your doctor. And each indication in this ASRM guideline on ICSI, they summarize the evidence, and ASRM summarized indication for ICSI with unexplained infertility this way. Overall, the current evidence regarding the benefits of routine use of ICSI for unexplained infertility is limited. The limited evidence suggests that ICSI may be associated with a decreased occurrence of failed fertilization, but does not demonstrate an improvement in overall live birth. Further studies are thus needed to determine the role of ICSI in this population. That's what ASRM says. Indication number 5, what about ICSI for low egg number? So in patients with diminished ovarian reserve, or there's a low number of eggs that are retrieved, should you do ICSI? Because maybe it will increase the fertilization rate, increase the number of embryos that are available, because we know not every egg is perfect, not every sperm is perfect. There's so much attrition between egg and sperm and live birth, right? So if you have very few eggs to work with, don't have a lot of room to kind of experiment. And some people say maybe you should do ICSI to increase your overall chances of success. There's one randomized controlled trial with 96 patients without male factor fertility who had 6 or fewer eggs at retrieval, and it was randomized to conventional insemination and ICSI. There was no difference in fertilization rate. There was no difference in failed fertilization. There was no difference in mean number of embryos obtained or pregnancy outcomes. Other studies looking at diminished ovarian reserve or poor egg quality, et cetera, as indications for ICSI also have not shown a dramatic difference. Along the same lines, indication number 6, should ICSI be used in the setting of advanced reproductive egg age. So again, the thought is that we know fertility declines with age. Could part of that be that as eggs age, the shell around them, the zona pellucida, is more and more difficult to penetrate, and maybe that ICSI will help increase the chances of success if somebody has diminished ovarian reserve, eggs of advanced reproductive age, etc. There's only one retrospective study trying to answer this question, and it really found no difference in outcomes and whether ICSI was used or not. And finally, indication number 7. Should everyone just do ICSI? Should it be routine? Should IVF clinics just say, oh, we're an all ICSI clinic, doesn't matter indication, we think it's best for everyone? The proposed theory is that it will decrease the risk of failed fertilization, it'll increase the number of embryos that are available, and hopefully in the long run, it'll increase the success, and people can have their family goals with fewer egg retrievals and fewer interventions. That's the theory, and that's the goal. A well-powered study trying to answer this very question randomized 415 couples with no strong indication for ICSI. They did not have a history of male factor. They did not have a history of failed fertilization. They were randomized to conventional insemination or ICSI and found, number 1, a higher fertilization rate with conventional insemination, which is very interesting. So 58% fertilization rate compared to 47% with ICSI. They did find a higher failed fertilization rate with conventional insemination. That happened 5% of the time in the conventional insemination group, but it also happened 2% of the time in the ICSI group. So the ICSI group actually did have failed fertilization in some of the cases in this large study. They concluded that the number needed to treat in order to avoid failed fertilization was 33. This means that in people who are doing ICSI without a strong indication, if you just make it routine, you would have to do it 33 times to avoid 1 case of failed fertilization. That's an interesting way to look at, like, how much is it indicated? Like, if you're that person that has failed fertilization, it's awful because you have to start all over again. But it's just kind of important to realize that of 33 people that do it without a strong indication, most of the time, people are going to still have fertilization with conventional insemination. So this study also looked at pregnancy outcomes, and they did not see a higher pregnancy rate in patients that did ICSI. And they conclude that ICSI should be recommended in only male factor fertility cases. That's what this particular study concluded. Topic number 4, what are the risks of ICSI? So we've looked at all the indications, and we've looked at whether it improves success rates or not, and when it should be indicated and when it isn't. But, why should we worry about it? Like, are there risks associated with ICSI? Because when people are thinking about doing it, there's pros and cons. It certainly costs more. It is more time in the IVF lab, and there can be risks with actually actively placing a sperm into the egg. You worry about damaging the egg. You just think about, like, any sort of medical intervention. You want to think about it before you just do it. And you want to think about pros and cons, risks and benefits. So the ASRM guideline is really saying if you've got an indication to use ICSI, it makes sense. Male factor fertility, history of failed fertilization, frozen eggs. But if you don't have a strong indication, you should think about it a little bit. There are some studies that show an increased risk of birth defects with ICSI. And this is what ASRM says. ICSI has been associated with a small increased risk of adverse outcomes in the offspring, and it needs to be reviewed, especially with patients. These associated outcomes are most often associated with the indication for ICSI. So if someone has male factor infertility, there might be a higher risk of birth defects, especially associated with sex chromosomes and things like that with the offspring. The thought is that it's not the ICSI or the process of helping with fertilization, but it's actually helping these men with male factor fertility conceive and pass on genetics that could show up in the babies. But what about when people do ICSI for non-male factor fertility reasons? Honestly, overall, the data is very reassuring that birth defects are not increased. Just like any medical intervention, it's important to review exactly why you're doing it, what the risks are, and have a thorough discussion with your doctor about what is right for you. So I'm glad you stuck around to the end of the video because I want to share with you some common conversations I have with my own patients every day about ICSI or not ICSI, and some questions I think that are important for you to talk to your doctor. So when I'm talking to anybody about getting ready to do IVF, there's lots of things that we go over. I answer their questions, I ask about goals, I talk about side effects, I talk about risks, benefits, etc. And there's 2 questions I always ask. How are we going to fertilize those eggs and sperm? And are we going to do genetic screening on the embryos? This is a topic I talk about with every single patient. If someone has a strong reason to do ICSI, like sometimes that's the whole reason a couple is doing IVF. The partner with sperm has less than 1 million sperm on the ejaculate. It's aspirated sperm for whatever medical reason. They are doing assisted reproduction for ICSI, then that's a very easy recommendation. When there's not a strong indication, I really do think about it with unexplained infertility. I just really hate those phone calls the day after the egg retrieval where there's no fertilization. And so I talk about it could be like a 10 to 20% risk of no fert depending on a lot of different factors. And so I kind of go over that with patients. But if there's a completely normal semen analysis, there's no strong indication, it's a discussion. And so my patients kind of come back to me. Some people feel like, gosh, we're already doing all of this science. Like, why not use every single tool that's available to us to sort of up our odds? So some people feel that way. Other people think, gosh, this already feels so scientific and we're not leaving anything up to chance or natural selection. I mean, maybe there's something about sort of the sperm fighting with each other to be that one sperm that gets in, or the egg does a great job of sort of selecting the perfect sperm. So they want to have some sort of natural selection. And so those are the discussions that we have. And a lot of it, we do talk about costs, we talk about risk, we talked about pros and cons, but those are some of the ways people sort of think about it. So questions to ask your doctor are, is there an indication to do ICSI? Do you recommend conventional insemination versus ICSI for us? What are the risks of ICSI? Is it something that you do often in your lab? Like that's, I cannot emphasize to patients how important it is, the lab that you're choosing when you're doing IVF and ICSI and assisted reproduction. But my clinic, Pacific Northwest Fertility, we have so much experience with embryologists that have been doing ICSI for years and years and years. But it is technically a skill. And so you want to ask, like, how much experience do you guys do ICSI a lot? And then just listen to your doctor. And it's okay to, if they have a strong reason, a strong indication, you feel great about it. If it's an ongoing discussion, maybe you say, hey, do you have anything else that I could read about? Maybe watch this video again and really think about what's right for you. But it is a really important discussion to have. I do feel uncomfortable if a clinic just says, oh, we're an all ICSI clinic and that's all we do. I do think it is an extra intervention. And I think that there should be an indication or at a minimum a discussion with a patient about pros and cons. I hope you learned something today. Like this video if you learned something. Comment with questions that you have, other topics you'd like me to cover. Be sure and subscribe to this channel so you get my weekly videos all about reproductive health. And until next week, wishing you love, luck, and pineapples.